Hello everyone. Good evening from SIG Clinical Aphasiology, ISHA, and this is the Aphasia Awareness Month. And here we are having a small activities, educational evening seminars for you. So we have a good intellectual evening today, and we have eminent chair moderator, Dr. Gopee Krishnan sir, our EC Aphasiology section, and we are going to have a good time understanding the verbs, nouns, agrammatic aphasia from a speaker who is the research associate and PhD scholar of Gopee sir. I would now request our moderator, Chair Dr. Gopee Krishnan sir. May I have sir?
How to move this thing? Okay.
So, Professor Gopee Krishnan sir in Indian modern aphasiology does not need an introduction. I'm sure all of the ISHA members and the students here admire him and his brain aphasia lab at Manipal. He's a very friendly, very scholarly, very approachable young clinician, aphasiologist, researcher. He has many accredits to his name, and he has international and national publications. He's a versatile speaker, resource person, and we are happy and very honored to have him today. Sir, you can take it ahead.
Okay. Yeah. Okay. So, good evening, all. This is Gopee Krishnan, as Ms. Sonal already introduced. So, I am here basically to introduce today's speaker, Mr. Wasim Ahmed. He is a grade 3 research associate working on a DST project here in Manipal with me, and he is also doing his PhD towards the end of it, I would say. And obviously, affiliation is with the Department of Speech and Hearing, Manipal College of Health Professions, Mahi, Manipal. And he has quite a good amount of good quantum of experience, as you see there, 14 years of experience in various capacities, I would say. And then his areas of interest are, as you see there, neurocommunication disorders, fluency, voice, and auditory rehabilitation. Earlier, he was on all this, but with me, he never got a chance to do all that, I would say. Now, the major achievements are that he was the, as you see, is a former principal and the reader, the ISHA Institute of Speech and Hearing Award India. He has secured several awards. As you see there, Shaila Vora Award and then Dr. Chowdhury Memorial Award, all that. And he has also published some papers. Yeah, the latest one is in that I think he will be mentioning about that in today's talk, and also some additional papers when he was engaged with the other institutions in the past. So that's briefly about Wasim, a very young, energetic, enthusiastic, and a big fatty Mr. Wasim. Okay, so now over to today's talk. A quick intro, I would say that agrammatism, or the grammatical deficits following aphasic brain damage, is actually a very an active area of inquiry in many languages, especially in English. And there is quite a, and what drives this grammatical deficits, I would say that like the verbs play a very cardinal or important role in the grammatical composition of any utterance that we speak. But unfortunately, many of these languages do not have or have not explored the verb processing deficits in detail. And those languages where some evidence is available, they are quite limited to the verb name processing. It's something like, naming of verbs. But verbs are beyond that, because verbs, I think somewhere I read or I wrote that the verbs act as the fulcrum of a sentence. Okay, because all the nouns actually get associated to the verbs. So verbs have a very cardinal role to play in the sentence formation, which is a hallmark feature of agrammatic aphasias. So, and more importantly, whatever has been published in other languages, especially I'm referring to the English language, is not directly applicable to many languages, and Indian languages are not an exception to that, because the sentence structure, all that is entirely different from English to English compared to our language. Therefore, whatever we read, or learn in our textbooks are not directly applicable to many of the processing deficits that we encounter. I'm sure Mr. Wasim would have also mentioned about his experience when he was trying to use some material developed in the English to Indian language. And therefore, we felt that yes, we need to sensitize our colleagues over here in India to about the verb processing deficits and what best can be done or what little can be done from our end. So with this short introduction, I hand it over to Mr. Wasim. Thank you.
Thank you so much. Especially a very good evening to everybody who are present here. Hope you're all safe and sound in your respective places. And I heartfully thank the ISHA and the office bearers for giving me this opportunity to share my experiences with you regarding this topic today. And I thank Sonal and Gopee sir for giving a wonderful introduction. I hope I'll live up to the expectations. And more importantly, I welcome all the dignitaries, my teachers, seniors, friends, and I can see some of my old students in the audience. Very good evening and welcome. Let me begin with my topic today. When I was given this opportunity, I was, in a fix that what should I be talking about now? Because with such an august gathering, where do I begin? What all do I include? So then I felt that I would be just addressing a known factor from a different perspective, that is in psycholinguistic manner. And I would make an attempt to rekindle our approach towards the persons with aphasia and how we can explore the importance and need of indigenous methods when we speak about rehabilitating persons with aphasia. So as we have student crowd as well as dignitaries here, I would try to keep it with a little basics as well as a little advanced aspects here. So just to brush up, aphasia, as we know, is an acquired communication disorder which is caused by brain damage and is characterized by an impairment of language modalities, which can include speaking, listening, reading, as well as writing. It is definitely not a result of a sensory or motor deficit, not confusion or psychiatric disorder. There are different types of aphasia that we have identified and it can be classified, but here I would be focusing more on the non-fluent type of aphasia because agrammatism is mostly linked with non-fluent type of aphasia, and we often see that in this type the comprehension is better compared to the verbal output. So agrammatism is a symptom complex that is commonly seen in non-fluent aphasia. It is characterized by limited usage of syntactic and morphological structures of language, and we often find only strings of content words, and they have greater difficulty in producing verbs in comparison to nouns. So before I proceed, I would like to just quickly review a few topics here. That will be, what are verbs? Verbs basically describe an action or event. Their existence within a sentence usually depend upon the associated nouns. So in the linguistic terminology, we call them as the arguments. An argument is an expression that helps complete the meaning of the predicate, which is mostly the root verb, and the association between a verb and its associated arguments is called as the argument structure. Now, the argument structure interacts with syntax and plays a pivotal role in a proper formation of sentences. So different types of verbs are determined by the number of arguments that it usually takes, and the type of verbs can also be determined by the thematic roles an argument can play, which we call it as the verb valency. To understand this better, I would like to give a few examples here. Thematic roles, what are they? They're also known as the semantic roles. Okay, and these semantic roles are the various roles that a noun phrase may actually play with respect to the root verb. See, here I have just given an example from 6 thematic roles. There are many more. Agent, it is the one who performs the action. In a sentence, if you take a grammatically correct sentence, what is an agent there? The agent is the one who performs the action. So if you take this example, the boy is giving a book to the girl. The boy is the agent here. Who is a patient? One that undergoes that action. So in the same sentence, the boy is giving a book to the girl, so the girl becomes the patient. So what is a theme? Theme is something that undergoes that action. They are sometimes interchangeably used, but I personally wouldn't recommend that, because there is a big difference where patient can alter or have an impact on the verb, whereas the theme won't. So look at this example where the girl is eating an apple. So apple does not have any control over the verb, so it is a theme. Similarly, an instrument, something that is used to carry that action. The man is turning the wheel with a stick. The stick is the instrument. Location, where the action is occurring. He is shoving the clothes into the cabinet. So there is a location to which that action is being performed. And source, she drew water from the well. So from where the action is originated. So if we take the argument structure taxonomy, three types of verbs can be seen: 1, 2, and 3 argument verbs. In the 1 argument verb, if you can see in this example, there is just the agent and the verb. Whereas when it comes to 2 argument verbs, there is an agent and a patient, or maybe a theme also that can come with the 2 argument verb. Similarly, in a 3 argument verb, we will see agent, theme, and location. It can be in any combination. There are 3 roles that can be taken together for that verb. Now, why we do this is these are based on how many minimum number of arguments are required for a verb. Okay, so here run is an 1 argument verb. Okay, admire is a 2 argument, and similarly shove is a 3 argument verb. So that many verbs are required for it to make a grammatically correct sentence. So in English, the subject verb object is the canonical form. And if we take this example, Ramu ate an apple, we can convert it into different sentences based on how we move these SVO, that is the subject verb object. If you want to form an object WH question, the same sentence can be changed as what fruit did Ramu eat? Similarly, if it is an object left sentence, it was an apple that Ramu ate. For a passive, an apple was eaten by Ramu. And subject raising structure, Ramu seems to have eaten an apple. So you can form as many sentences as possible by moving them. So whatever may be the sentence, the most important thing that we need to know is Ramu still remains the agent and apple still remains the theme. So there are 2 major operations that take place in English in order to form sentences. One is merge, second is move. Merge is a process where syntactic objects are selected from the lexicon to combine in order to form a higher order category. Whereas move is a process where a particular syntactic category is moved to another position in the syntax tree. For example, if you see this WH movement happens in the first and second sentences, whereas the noun phrase movement occurs in the third and fourth. So when WH movement occurs, a question can be formed and even an object left can be created. When a noun phrase movement happens, a passive or subject raising structures can be created. So sentence production is often dependent upon the number and type of number and argument types required by a verb. So higher the arguments, greater is the difficulty in processing that particular verb. So this factor has been observed in multiple languages, and verbs with a higher complexity of argument structure have greater phrase structure building. So if you want to put it in a very simple way, you can say that 3 argument verbs are the most difficult compared to the single argument verbs. So what does the Western literature say? I have just compiled 3 major aspects here based on agrammatic features, which are most commonly reported. One is a difficulty in assigning thematic roles to those arguments that have been moved from their canonical position. That means they can only make simple sentences. Simple sentences, they are in proper SOV or SVO position based on the language of concern. In here it is SVO, pardon me, I put it as SOV. SVO in English, and if this move from their canonical position, that is the actual position that they are supposed to be, but they have moved from their regular position, those kind of sentences like the passive, the object left, the subject left, they are unable to produce such sentences, whereas the simple basic SVO structures they are able to do it. And most commonly they have also reported missing and or misordered verb arguments, that is verb object subject or verb combinations. Like in one of the articles they had mentioned about people trying to say this Cinderella picture, the Cinderella story, where they say that phrases like fit her, to fit something like that, which are verb object and subject object combinations, which do not qualify as a grammatically correct sentence. So in Indian literature, we have quite a good amount of work that has been done. The first one is in the 1990s, where Dr. Bhatnagar had extensively explained a single subject from a Hindi-speaking person, where all the spoken sentences were simple and they were canonical SOV sentences. Most grammatical errors were involved with the verb phrase structures, and the auxiliaries and the main verbs were most impaired in their expressions. The verbal inflections were the second most disturbed aspects. The substitutions or the erroneous substitutions were more common compared to omission errors, whereas the English literature says that omission errors are more common, as we saw in the subject verb or the object verb combinations in the previous slide. He also mentioned that principal verbs or the root words were better produced compared to the morphosyntactic features. Similarly, 90s, Karant and Bhatt had spoken about a Tamil-speaking, rather a set of Tamil-speaking brokers' aphasia patients, where they saw that shorter MLU with mostly content words and telegraphic speech was reported. Stereotyped usage of one or two inflectional morphemes rather than omissions were more commonly seen. The same way as we see that more of substitution errors are here, and substitutions of inflectional morphemes were found to be higher. Whereas in English speaking agrammatic subjects, it was more of omissions. The same findings were reported here. And one important aspect that they had mentioned in this study was that why this was happening is because English is a free word order following language, whereas Tamil is a more of a agglutinative and morphosyntactically rich language. This happens in other languages in India as well, especially the Dravidian languages. Now, what is this agglutinative nature? The agglutinative nature makes most of our languages distinct from English. Due to this nature, multiple words are formed from a single root word. Now, if I just take, for instance, I'll take a root word. This root word nodu. Nodu in Kannada means to see or to look. I add multiple suffixes to it or different suffixes to it. You can see that the entire scenario changes here. So nodu, noduvudu, noduttiruvudu, noduvanu, noduತ್ತಿದ್ದಾಳೆ, ನೋಡುವವನು, ನೋಡುತ್ತಿರುವಂತಹ. So if I say, if I add suffixes to the root word, it not only becomes a different verb altogether, or rather, a complete verb altogether, it can even qualify as a verb phrase when it comes to agglutinative sentences, agglutinative languages. This could also be a similar situation in other languages. So there were similar findings that were reported recently in Malayalam-speaking participants by Dr. Aital, Dr. Veena, and Dr. Rajshekhar in one of the students' dissertations, where the tenses were the most difficult to comprehend, and the production deficits across most of the morphosyntactic structures were seen, and utterances were characterized by only content words without any complete sentential constructions, and transitive verb productions were comparatively better. So if you see that verb naming in most of the places is kind of better, but it does not qualify to say that the person has recovered to a large extent without sentences or without the ability to form sentences. So another one that I could come across is in the Kannada-speaking brokers aphasia patients, where tenses were the most difficult to process. Nouns were used in abundance compared to verbs, prepositions, and auxiliaries. And also, the authors tried to attribute this to the lack of access to such syntactic structures for agrammatic subjects. And they said, if they find it convenient to express using simpler sentences were made. I mean, like, if they could access these aspects, they could actually put it into their, regular sentences as well. So it is again simple sentences with, if at all produced, and mostly single or simple content word based production. So further, the authors postulated that in case an aphasic subject could actually comprehend these complex syntactic structures, it would certainly be evident that they would be present in their verbal output also. So if they could comprehend it, they could produce it. So some essential factors that I would like to ponder upon is the Western literature often incorporates standardized, validated tests and therapy protocols into their experiments. So this often enhances and facilitates cross-central and cross-cultural comparisons of their results. And clinically, such tools are very vital to identify the actual disturbances in the language of the clients and will also help us to address most of these nuances in agrammatism. So what should a comprehensive test be like? It should be able to assess verb comprehension, verb production, verb argument structure production at sentence level, canonical sentence comprehension and production, non-canonical sentence comprehension and production, and verb argument labeling. Unfortunately, none of the available tests can comprehensively assess all these aspects together pertaining to agrammatism in English and leave one or more aspects unexplored in each one of them. There's but one test that we did come across, that is the Northwestern assessment of verbs and sentences. It is a comprehensive test that can assess both production and comprehension of 1, 2, and 3 argument verbs, verb argument generation, noun phrase and WH movement in both comprehension as well as in production subtasks at sentence level. So this was one, or rather I would say the only test that we could actually see, which was a very comprehensive and a holistic one. So what are the recent advances that we can see in terms of verb and verb processing in terms of therapy technique? Verb network strengthening treatment program has gained a lot of momentum in the past few years. It was aimed to promote, or it was developed in order to promote augmented lexical retrieval abilities beyond the explicitly trained item. That means the generalization would happen better in this therapy technique. So following therapy, participants could actually communicate using simple sentences, even at discourse level, with a better accuracy to convey their idea. So they had hypothesized that with the systematic activation of the agent and patient thematic roles around a particular target verb, an increase in the activation of the concepts that compromise the verb network can be seen. So what usually happens in VNest is thematic role assignment is trained inherently. So participants are trained to determine the agent and the patient or the theme for a given verb. So at least 3 or 4 agent verb patient sentence combinations are elicited in the technique. So for example, if I put together one example here, see that chase is the target verb for that particular day, and at the end of the session the person should have been able to generate a sentence of this sort, that is, who is chasing whom or what, where, when, and why. That means tiger chase deer in the jungle in the morning because it is hungry. So not only was it the agent and the patient generated across, around the target verb, but also other elements, that is where, when, and why, were also generated, within this therapy program. So what are the advantages of this VNest? It augments lexical semantic relations and activates episodic memories in the subject. It was also said that it may increase the possibility to strengthen the semantic representation of that verb and its relationship with the thematic roles. It may also strengthen the specification of the predicate argument structure as well as the basic syntax of a sentence. And options to improve sentence production by integrating semantic, syntax, and thematic role assignments was also a good advantage of this test. But there is one shortcoming of VNest. It does not promote syntactic depth or accuracy. We need to go beyond VNest. When I work with VNest and I used a translated version of VNest, I could see that the participants could generate the elements individually and try to put it together, but they couldn't transfer that into discourse. Now, that is a big shortcoming because you are not promoting syntactic depth or syntactic accuracy here. So there are other techniques like the TUF, that is the treatment of underlying forms, which focuses both on production and comprehension of grammatically correct sentences, which is not done in VNest. TUF believes that individuals with Broca's aphasia mostly retain access to verb argument structures during comprehension, but they are unable to transfer it into production. That means comprehension of grammatical aspects might be present, which might not happen in production. Actually, the NAVS test as well as the TUF is a combination tool. In Northwestern University, there is a package which comes along with a test as well as this TUF. So TUF is designed based on the test. So whatever the test can assess, the TUF tries to correct that. So verb comprehension, production, argument comprehension, production, as well as sentence comprehension and production. So these things are tested in NAVS as well as TUF. Tries to treat the same aspect. So it can be used as a pre and post therapy tool. So TUF emphasizes the importance of canonical sentence formation to help agrammatic subjects to overcome their difficulties pertaining to sentence comprehension and production. That means the canonical form of sentences are the key highlight of TUF that needs to be that are trained. Whereas in VNest, you are only identifying the elements, but here the grammatical correctness is emphasized in TUF. So TUF has been found to be effective in the following aspects. One, improved comprehension and production of trained sentences. Successful generalization to untrained sentences, and this is a very important factor here. The third one, the enhanced generalization can be seen when the treatment direction is from more to less complex. That means TUF is one of the therapy techniques which which emphasizes on the factor that when you train difficult sentences or the non-canonical sentences which are difficult to process, the canonical sentences automatically become better. So it is a reverse direction in which they suggest that the therapy should happen. Whereas in VNest, you are going towards a bottom-up approach where you are going from identifying the elements, putting it together, and then trying to form a canonical sentence. Whereas TUF has gone ahead, which says that you work from the reverse, the top-down process, where the non-canonical sentence, the most difficult ones are trained, and the generalization comes towards the simpler ones, that is the canonical sentences. So I have also noticed, and my discussion with my friends who work in this area in the United States have told me that they usually sometimes use it in combinations, where once they're able to achieve to a certain plateau at VNS, they shift to TUF in order to make the patient much more better, and then try to move towards the naturalness of language. So substantial changes in discourse can also be seen from this treatment effect, and improved processing of trained sentences can be seen in real time when you do in TUF because of the test that comes along with it. And the best part is the gains have been mapped using fMRI, showing that there is a very good cortical reorganization that happens using TUF. Now, what is the scene in the Indian scenario? We have such extensive exploratory work undoubtedly, but we still have a lacuna that exists, as comprehensive as well as validated protocols are unavailable for assessment and management of agrammatism. In a multilingual nation like ours, it is of paramount importance to have linguistic and culturally appropriate tools. So why don't we just adapt and use translated versions of the pre-existing foreign language test and therapy programs? A common question that we can. But is it so simple? I don't think so, because it is practically inappropriate to do that. For a few examples that I would like to just share with you with our observations, as well as what has already been reported in some of the literature. Unlike English, Kannada is a left branching head final language. The canonical word order is different. That is, subject, object, verb, with the main verbs preceding their auxiliaries, genitives preceding their nouns, and complements preceding matrix clauses. Its morphology is agglutinative and primarily suffixal. So in such a different language, we can also see that the verb valency categorization can vary across languages. That is, if a verb in one language is a one argument verb, it can be something else in a different language. For example, if I take the verb teach here, teach is a one argument verb in English. Whereas if I take the Kannada version, that is kalisu, kalisu is teaching. Kalisu in Kannada is a two or even a three argument verb, because the goal is obligatory when we mention here. When I put it in a sentence, okay, if I put it in a sentence that I taught for a while, it is quite acceptable in English. Well, the Kannada version, Nanu Kaliside, meaning I taught, without mentioning what did I teach or whom did I teach, whatever that she can taught can be improper, because it should have either already appeared in a previously in the discourse, or it has to be explicitly mentioned. So is it the same with other Indian languages? I've just given a few examples here. I hope you can tell us that when we discuss it, whether it happens the same way here. So I thought, teach. I've taken that as an example in different languages. I would be glad to discuss this when we open the discussion. Does it happen in the same way in other Indian languages? In Kannada, it definitely happens. Teach in English is a single argument word, but definitely not in Kannada. It is more than that. Also, we can observe that predicate adjectives in English could be a full verb in Kannada. Example, consider the sentence, he is angry. Okay, here the word angry is actually a predicate. Okay, when we look at it in the English form. But in the Kannada version, if I say the same sentences, he is angry, avanu kopisikolluತ್ತಿದ್ದಾನೆ. Kopisikolluತ್ತಿದ್ದಾನೆ is a full verb. Okay, it's not a predicate adjective. So does it happen the same way in other languages? Okay, I just want you to ponder upon this and discuss with us once we open the discussion. So does it happen in the same way? I feel it happens to a large extent to most of the languages. So recently we did come across some good work, that is semantic queuing of verbs and its thematic role was introduced for Kannada speaking persons with aphasia. The authors reported discern positive gains across trained conditions and discourse genres across all the participants, with marginal gains with untrained stimuli. And this therapy also aided in modifying the error patterns exhibited by persons with aphasia, and all participants showed upgraded performance on the standardized language test batteries during post-therapeutic evaluation. So what do we have to offer here now that we understood that there is a lacuna where we do not have a comprehensive test battery, we do not have a comprehensive therapy program? What do we have to offer? So we are coming out, or rather we will be very soon coming out with a published first of its kind standardized set of 269 pictures that are based upon this argument structure classification. In that you can access it, it will be in open access, where you can get around 269 pictures which are divided into 3 different categories: 1 argument, 2 argument, as well as 3 argument verbs, which are not developed based on verb naming. They are rather developed based on a sentence. So if I say a boy is running, say, and then a man is digging, or rather a boy is giving a rose to a girl, so it is developed based on a sentence and based on the psychometric parameters across a large set of participants, normative participants, and they have been set in such a way that you can choose the verbs based on the 4 psychometric parameters, that is the name and argument agreement, familiarity, image agreement, and visual complexity, as well as frequency scores for that particular verb. So clinicians and researchers can choose stimuli from our set and incorporate it into different experiments, or rather developing assessment tools, or developing therapy programs, or even in your day-to-day therapy or assessment programs. You will have a standardized value to which you can compare your responses that you get from your clients, and you will have a standard baseline for it. Going further, we are also working on a comprehensive agrammatism test, or rather I would say it's a comprehensive agrammatism assessment test battery, because it will have multiple sub-tests which in itself can stand alone as a test, which will assess most of the aspects that are required to assess the nuances of agrammatism. And a comprehensive agrammatism therapy program is also developed, and we are in the process of validating it. So very soon these 2 will also be available for access to clinicians as well as researchers. Rather than trying to adapt or translate work or already pre-existing work from a foreign language, I feel that when we have a foundation in an Indian language, okay, we can easily adapt to other languages, and then more comprehensive work can be done in terms of agrammatic rehabilitation. Now, I'll put a few final thoughts here. It's like, the pandemic has pushed us to rethink and renovate. So why should this not be applicable to the way we approach persons with aphasia? Life is hard for all of us, but it is even more unfair to a person with aphasia because an entire family might be dependent on them. Rehabilitating up to word retrieval is good, but is that enough? Okay, we usually get overwhelmed when we say that my client is able to name 200 nouns, 50 verbs, but is that enough? Is he able to transfer it into a communication platform? When he tries to communicate, is he able to put these verbs and nouns together? He has it in his repertoire, or he has regained those words in his repertoire, but he is able to put it together into form of grammatically correct sentence. That's mostly not happening. And natural language usage is possible only when the person with aphasia regains the ability to communicate in sentences, as he used to do before the stroke. We should never forget that this is a man or a lady or a person who had the ability to communicate in sentences. Maybe he could even use the language to different wonderful levels. We don't know, but at least if he can make basic structure, common sentences, or even grammatically rich sentences, he can be better rehabilitated personally, professionally, as well as socially, which is definitely a right of every person. He needs to be rehabilitated in this way. So I, as a clinician, had always felt that this shortcoming where I would stop or reach a plateau and didn't know what to do beyond that. The naming is happening, the person is able to identify whether it is picture naming or whatever it is, but as long as the naturalness doesn't come, the rehabilitation is not over. And now that we have understood to a certain extent how we can bring a person back to his original level, probably I feel that we will not be left with a blank space that we cannot go further beyond naming. So let us go beyond just the naming of nouns or verbs. Let us focus towards giving a communicative freedom to that person, and let us try to change their life to the better. Thank you very much for your patient listening. I will be very happy to discuss further.
So thank you, Mr. Wasim, for that excellent talk. So Professor Apurva Paurani has asked, syntactic anomaly and semantic anomaly judgment task with and without even related potentials. So that's a question. Do you have anything, Ms. So I just read out what has been typed over here: syntactic anomaly and semantic anomaly judgment task with and without event related potentials. Any thoughts on that?
So yes, I have been trying to explore that aspect because electrophysiologically, I think P600 is what is commonly used.
Yeah,
And
exactly.
yes, P600 is because I have a little limited knowledge about this. I'll just try to say whatever that I have explored so far. So I think
Wasim, I'll just take it over because since I am the moderator. Yeah, so actually the N4 is for the semantic, that is N400 is for the semantic anomaly, and that is about a negative peak at about say 300 to 500 milliseconds in an ERP. And later, the syntactic anomalies can evoke a positive P600 peak at about say 500 to I would say 7 to 800 seconds. You can observe a peak in the waveform, especially when you confront with this syntactically anomalous sentence. So this can be obviously, and further, in my knowledge, this has not been explored in any Indian languages, but this has been richly reported in English language. So I think we can move on to the next question. Do you also recommend doing V-nest with what interest the person with aphasia or general verbs used? Okay, I think the question is like that. Do you select the verbs based on the patient's interest or the general verbs?
that's a very good question, actually. Yes, sir. This all started with this question, in fact. When I used to work with a translated version of V-nest, The English version of Venus has recommended a fixed set of verbs that needs to be taken and to stick on. When we tried to choose the verbs, it was initially based on the interest that we had taken. And when we took the verbs, we would just think that what big work is there just to choose a verb? There are so many verbs that we can access on the internet. Just choose any verb and just start off. As and when the therapy was progressing, I could realize that it was becoming difficult for the patient on a few occasions, and because we couldn't get enough exemplars to generate, it was so that sometimes it would be very easy. I was like, oh, how is this difference happening? And then when I started exploring what are these verbs, then that is where I started realizing that there are argument structure based verbs, and this is how we need to go in a systematic way. Yes, keeping their interests and choosing will definitely be good, but I would suggest that when we do adapted version of Venus or a translated version of Venus, try to start from the single argument verbs and then gradually move to the three argument verbs. Because if you choose a difficult argument verb here, the processing can actually be not that great, and you can actually put the person into trouble, and you will have unnecessary large gaps between the responses, and the motivation can come down. So start with the easier ones and then gradually move to the
so do you think, by saying that, do you think that like you are not recommending the complexity account of treatment effectiveness or efficacy, that is moving from a complex to a simpler one as they mentioned or as they reported?
In TUF, yes sir, in treatment of underlying forms is the only one therapy program that I have come across which says that we move from a top-down approach, that is from a complex to a simpler one. Practically speaking, it is quite tough, sir. It is very difficult to implement a non-canonical sentence then coming to a canonical one. In fact, I would just like to give one example from my own assessment tool that I have been developing. I can see that non-canonical sentences, it's very difficult even for an anomic aphasia person. Even they fail to use that. So when that is the case, when it is a anomic condition, transcortical motor or broadcast, they will terribly fail on that. So I would suggest going from canonical to non-canonical.
Can you listen to me, Ms. Can you hear me?
Yes, sir.
Okay. Keep the answers short because we have quite a few answers to address, questions to address.
Yes.
Okay.
Yes.
Yeah. So if you're done with it, can we move on to the next one?
Certainly, yes, sir.
Okay. So the next one is from. Okay, next one. Let me see. There's a comment that it's a good idea from Abhilash Ghade. It's a good idea to do a top-down approach for maybe non-fluent aphasia. That's a comment. What about deep speech language structures like problem with the rhyming, etc.? I did not quite get that question, by the way. Deep speech language structures like problems with the rhyming. Perhaps if you did not really capture the essence of the questions, please, the audience, you can always get back to us and we'll be happy to address your queries. Okay, you can email us. So maybe one Ms. Sonali, which, yes, slide 35 is excellent from the same person. Yes, thanks for that. Credit goes to Mr. Wasim. Next, Joanna. Can the same be modified and used for children with language disorders to proceed beyond the single words? Yes, Wasim?
I haven't explored that, but I think yes, the verb set that we have spoken about can be adapted for children as well.
Certainly, it can be and it needs to be, because I think especially children with a specific language impairment, especially the grammatical subgroup, would be definitely benefiting from this kind of argument structure, because they will understand the dynamics of the language by orchestrating or changing the nouns and verbs within a sentence. So they will get the theme, in my understanding, I am saying. So even when we were developing this material as well, I think Wasim would agree that I think one sentence I finally added in the manuscript was in the conclusion part, that it would also serve the for serve children with a language environment such as SLI. Are you able to
Yes, yes.
recollect the
Correct, correct. Yes, sir. I remember that. Yes, sir. Absolutely.
All right. Okay. So next one is from Dr. Paurani. What you have proposed today is basically a part of impairment-based approach. But how can we integrate verb and syntax-based therapy with now popular live participation approach?
Sir, here I think
Had this question not been asked by Dr. Paurani at the end, I had kept this question for you, Wasim. Yes, go ahead.
sir, as I mentioned, sir, I mean the reason why sentences have to be there, because without sentences the person wouldn't be able to express himself more effectively, and just single words or a single string of words do not qualify as a sentence, and they do not make any much impact on the listener to whom he is saying. So obviously the person needs to have a good communicative platform or a freedom, that I would usually use the term, where he'll be able to rehabilitate better when it comes to whether his profession or even socially. We do come across so many patients who are just within 30 to 40 years of age, and they have lost their livelihood because of this.
Maybe I get the point. Maybe my thoughts to that question would be, to Dr. Paurani, would be that, see, one treatment will not fit all, and there would be people with who have very less amount of verbal output. For them, this may not be a viable approach. This may be better suited for people who have some verbal output and who still find it difficult to, say, manipulate the words within the sentences, etc. But obviously, spectrum aphasia is a large spectrum, so we know that one size will not fit for all. So there may be a small proportion of patients or clients who would be benefiting from this treatment approach. Okay, all right. Next would be very thought-provoking lecture. Yes, Saraswat. Okay, it goes to Belur. Rajshekhar sir has asked, can I be permitted to comment on this presentation? Sir, you want to come on live 1% or you want to chat? You are permitted, sir, of course. You can even send a message to me. I can read it out.
Take him in the panelist station. 1 minute.
Yeah. Sure. Otherwise, sir can actually send me a message. I can read it out on his behalf. Yeah. I might take another credit card. Good evening, sir. I don't know. I didn't get what exactly meant by the audience, the participant. So would you suggest that one begins therapy with word retrieval and work up towards more complex communication abilities? I don't know, Prabhu. To you?
No, sir, the voice is breaking. Can I have the question once again?
Yeah, I will repeat. So would you suggest that one begins therapy with word retrieval and then work up towards more complex communication abilities?
Yes, exactly. That is the principle of VNest. VNest is for verb retrieval initially, and then you work up towards forming a canonical sentence.
Okay. So could you please suggest a right candidacy for VNest and TUF?
Right candidacy, yes. See, VNest can be taken up whenever a patient has at least like 30 to 50 nouns. That is, he's able to, without any cueing, he's able to freely name 30 to 50 nouns and around 10 verbs. Okay, you can begin from there. And TUF is once the person has achieved a good amount of performance on VNest and you do not have much to progress further, that is when you move to TUF.
Okay, thanks. Yeah, I hope that answers that question. And next is, what would be the various steps in this hierarchy? I think that's a basic topic to be covered, which is beyond our talk. Perhaps the speaker or the person who asked, I'm not getting the word, can perhaps get back. Maybe you can get back to us if you don't have sufficient resources. We can share that with you. Okay, that goes to Ms. Aruna Prabhu. Little bit of expansion on tough with the example. Again, yes, we can help you. Perhaps if you get back, I think that person has Kranti Acharya has already left. So next is saying this in regional languages. Might doesn't seem grammatical. That might is in no inverted comma. Okay, that's a note for you, Wasim. That was not grammatical. It seems okay. Yeah.
I didn't
Then
get that point, sir.
you didn't get it?
No, sir. I didn't get the point.
Saying this in regional languages, in inverted comma, might, okay, where is it? Does not seem grammatical. That's a comment, okay. So perhaps you can work on the grammar aspects. You can work on the grammaticism that you have, perhaps all of us have. Okay, so then next one, interesting comment. Does Venus help with global aphasia to facilitate comprehension in an acute care hospital? That's a question.
No. Venus, you can, as I said, Venus begins when you have reached a certain level where the person is able to name without any cueing.
Yes.
So
yes.
it is at a little later stage, definitely not at acute level.
Yeah. Okay. Next one. In my 13 years of experience, I came across only one broker aphasia who had expressive vocabulary to be able to use Venus for TUF. Would you use it in Wernicke's or Anomic too?
Yes, we can. Yes, Venus can be used. Venus can be used for fluent aphasia also. It can be.
All right. Okay. Where can I buy Venus as well as the verb pack?
Venus is, I mean, it's not something to be bought. I mean, the article is there.
Yeah, it's
not a commercially available. This one, it can be. If you get the idea, you can start working on Venus right away. It's not a commercially available therapy or anything. It is open for all.
Yeah. And the verb corpus, verb pack, perhaps the one which we developed, it will be available to you freely shortly. Okay, that goes to Sonal, which is combined therapy approach is needed while therapy or can we work solely on Venus or tough, that is TUF, for modification of sentences, because many a times participant level feels monotonous. Could you please suggest? Shall I repeat?
Yes, sir. Once more.
Okay. Is combined therapy approach needed while therapy or during therapy, or can we work solely on Venus or TUF? Okay. Because
yes,
your answer.
Yes, combined. Okay. As I said, there is a hierarchy when it comes to therapy. If you take from global to anomic level, see, Venus comes at a certain level where you are able to name. That means the previous therapy techniques were also there. That is the word retrieval therapy, for example, the SFA and PCA, other things. And when you're working on Venus, you can integrate TUF and slowly, gradually move towards TUF completely. So it is quite possible, but I would still suggest that go in a hierarchy way, because it will be much easier for the patient and you won't be bombarding the person with too much of linguistic stimuli to process. So go one step after the other. Once you are declining a particular therapy technique, start with the next one, so that they can smoothly move from one therapy technique to another.
Okay. Yeah. So the next question: could you please explain with examples that how do we go about implementing TUF? I think the proponent of this question can get back to us. We can perhaps help them, right?
Yes,
because right now our time doesn't allow for all the other explanations. Next, if the client is multilingual, then how to initiate assessment and intervention? Which language we need to prefer and target in assessment and intervention first?
Okay. Whichever is much more easier.
Sorry, you want how to initiate the assessment?
In which language? The language preference.
Go ahead, Wasim.
Yes, sir. So in that, I mean,
which is basically.
Your voice is breaking, sir. I can't hear you.
Sorry, did you get the question? Am I audible now?
Yes, sir. I feel what you asked
Am I
is that
audible
which
now?
language to prefer. Which language
Exactly,
to prefer?
yes.
Okay. There are two ways of looking at it. One, the person's preference itself. Some of my patients have told me to take therapy in a particular language. A Kannadiga who asked me to take therapy only in English because he wanted it on the professional front. That's okay. Or else, if the choice is on me, I would go with the language which is much more easier to access for him.
Okay, okay, thanks. Next is from Dr. Kiran S. A great discussion and moderation. Can you please explain the utility of verb training in more severe forms of non-fluent aphasias?
Verb training in
More severe forms of non-fluent aphasias.
more severe. Okay.
Verb
Yes.
training in more severe forms of non-fluent aphasias.
Definitely, verb should be taken up as soon as possible, because we most of the time when we are working on naming, we just focus on the nouns. But verb now, therapy or verb naming should also be incorporated as soon as possible, so that once you have a set of verbs and nouns in your repertoire, you can move to the higher order therapy techniques like Venus and so on.
Yeah, I think yes. Even I agree with Ms. Wasim, because Kiran asked maybe like what he intended is in more severe forms. Even I would say that as a speech language pathologist, it's not there's no point in training only the nouns, because it wouldn't serve much of the communication purpose as long as we train the verbs so that like they can use those nouns to club with the verbs and to make some sort of like, even if it is simple, some communicative utterances or utterances of some communicative relevance. Okay, so I
So
think
just
yes.
one more point that I want to add on to that, sir. Verb, the Venus principle itself, that is what it was developed on, which says when verbs are trained, the associated nouns get activated. That is the network, the verb network that they were talking about.
Okay, yeah, next is according to theory, reverse recovery, nouns are most affected ones. Is my understanding wrong? I need to read on a reverse recovery. Perhaps if Wasim, if you have confronted with that, you can comment. Yes, we can get back to our textbooks.
Yes, sir. I don't have much to comment on that, sir.
Sorry for that. We will update ourselves. Wonderful presentation. Yes. Do you suggest that test and treatment in a discrete environment or create an opportunity to elicit the target structures more naturally?
So it's breaking, sir. Can I have the question, please, once more?
Okay. A wonderful presentation that comes goes to you. And then the question is that, am I audible, by the way, Wasim?
Yes, sir. Yes, sir.
Okay. Do you suggest the test and treatment in a discrete environment or create an opportunity to elicit the target structures more naturally?
Actually,
yeah, go ahead, please, if you got that question. Yeah.
I got it, sir. I got it. Initially, Venus does not ask for pictures or any other supportive material to be used for eliciting the responses. They just go for a direct conversation level. So they do not want additional aspects to be added that can influence the patient's response. So they want the responses to be self-generated. So if you are going by the classical one, you have to stick to that.
Okay, the next is a comment for both the presenter and the moderator. So since it is both praising both of us, I thought we will keep it aside because there are a few more. Okay, that's from Mehboob Sharnas, from Mehboob Sharnas, developer of software speech. Okay, yeah, thanks for that. You can say one thanks, Wasim.
Thank you, sir. Thanks.
Yeah, okay. Not to me, to the to Ms. Mehboob Sharnas. Yeah.
Yes, Shana, sir. Thank you so much.
Okay, so next, Dr. Pauranik, congratulations, awaiting your works to see in light of the day in open access. Yes, sir, you can see shortly. Thanks for that. And yes, can you again let us know the elements of a test of agrammatism should we have?
Yes, sir. I think I mentioned in one of the slides. So, what should be agrammatism test be like?
Yeah, means verb, then the argument and the sentence, both comprehension and production. That's what you mentioned, right?
That is what it needs to assess. Yes.
Yeah. Then any experience of crossover benefit of Venus and TUF intervention in one language to another, Indian to Indian or Indian to English, again from Professor Paurani.
Yes, I have scientifically not explored it, but yes, I have experienced it in my patients. I have seen that when I have trained them in English, the transfer has been seen in the other languages also. Especially, I remember a Tamil-speaking Broca's Aphasia patient, where I could see that his conversation in Tamil had become much better. When I was training him explicitly in English.
Okay, we have a few more questions. We'll go a bit quickly. Next is there a relation between web processing in agrammatism and spontaneous writing?
Spontaneous, sir?
Writing. Verb processing in agrammatism and spontaneous writing, is there a relationship?
Yes, I cannot comment with a fully affirmative one, but I did notice in one of my patients that in VNest we already provide an opportunity for the person to come out with the responses, verbal responses, but he preferred to write it by himself. So he was feeling it better to generate these elements by writing and then saying it out aloud, and then it transferred into a conversation. Probably it might help, yes.
Okay, next is, it was very informative. Thank you so much. Can you suggest any technology-based apps or website to use this Venus, especially to adopt during online therapy for persons with aphasia?
No, I have not come across anything of that sort, but this can be created in PPT by themselves. The clinician can make it by themselves. That is how I usually work with online cases. So the steps have been converted into slides, and then I use it in an interactive mode on Zoom to communicate with the patient. It can be done very easily. It's not difficult at all. You can in fact see a YouTube video which is very informative on this. It is available.
Yeah, I can say that if you understand the dynamics of that intervention, any of this intervention program, whether it is TUF or a Venus, I think you should be able to just do it with a simple PowerPoint presentation. Am I right, Wasim?
Yes, sir. But in TUF there is it's a commercially available test, and we need those stimulus cards and other versions, sir.
Venus,
but Venus, yes, sir. But Venus, yes, we can use it based on the dynamics of the test.
Okay, Digvijay Babu, your old classmate. Does verb training facilitate spontaneous recovery in severe non-fluent aphasia? He is currently working as an audio linguist.
Does it promote spontaneous recovery?
Yeah.
Possibly. In a very few cases that I have met, I have met them during the spontaneous recovery period, and I have seen that better outcomes have come once the recovery happens. But most of the cases that I usually meet are chronic, even beyond 10-15 years. So even there, I have seen improvements coming through Venus.
Okay, anyways, to Digvijay, spontaneous recovery is not a training related recovery, Digvijay. So anyways, it might be possible that you cannot stop the spontaneous recovery. Perhaps the training can induce some sort of maybe stimulate some spontaneous recovery, which is more directly related to the treatment, but both cannot be equated. Okay, in research, we do not want these two things to be mixed up. In fact, the one is a spoiler. Spontaneous recovery is actually interfering with the treatment related recovery means you are actually losing the actual effect of treatment. Okay. Yes. More doubts, we can get back to this. Okay, great informative session. Next is Sanika. In aphasia, one aspect that plays a role is spontaneous recovery is being said. Now we have all these therapy techniques wherein I believe that hospital environment can influence the effectiveness of the service delivery, especially IP section. She's referring to our unit, I believe. So now, how do you deal with this? Wait for the client to get discharged from the hospital, assuming that spontaneous recovery will not occur, and then continue with this specific treatment approaches later?
I don't think that should stop us, sir. If the patient is ready for a Venus program, then I think it can be started. As I said just for the previous answer, that during the spontaneous recovery period, when I have given Venus therapy, I have seen better results. So that shouldn't stop us. If, as I said, when is the patient ready? When the patient is able to name and retrieve a few nouns as well as verbs in his repertoire, then we can begin with Venus.
Yes, Sanika, whether they are IP or OP, if the patient is fine compliant with this training program, just go ahead. Okay, thanks for that. And Digvijay Babu, yes, again, he has complimented both you and his teacher. That's me in the past.
Yeah.
Okay, anyways, thanks. I think we are done with it, Sonal. Have we exceeded the time?
Yes, sir.
Yeah, can I come
We
online,
are good to
Dr.
go.
Gopee?
Sir,
Yeah,
please,
Dr. Gopee,
sir.
can I come on?
Rashika, sir.
Yeah, 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 yeah.
Yeah,
See,
Yes,
actually, I mean,
go ahead.
Please go
yeah,
ahead.
there are no questions to be asked. I just wanted to only comment about this session, the presenter and the mentor. Okay, I must say that it was a great presentation by Wasim. Okay, and no wonder that the one who has kind of tutored him is none other than the great researcher Dr. Gopee Krishnan. Okay, what I liked in this presentation was his candid expression of the need for his research in terms of the comparison between what has been done in the Western literature as compared to the Indian, not belittling the Indian studies, but the systematic approach or the kind of the formalized thing which is done in the West, which was absent in the Indian setup, which I think probably prompted him to do this. So I think this has resulted, or this will result in a very comprehensive assessment tool as well as an intervention kit for Agrammatism, which I think is is really wanted. Okay, and I think he very well took up his presentation in a very phased way, like giving the basics of of what exactly is agrammatism, and then explaining about the verbs and all that, which I think he had considered the different layers of people who have been the participants. I think that made a very interesting thing. And then I think he was very clear about what he wanted to do, and knowing him being involved very sincerely with therapy for the persons with aphasia. Okay, I really would envisage that this and the outcome of this research, okay, will definitely take us a step ahead, okay, in giving a better deal to these patients. Like you rightly said, are we happy with just this the people saying he can say so many nouns, so many verbs, or you want it to be a step higher than that? Because it's always, we always try to go one step up and see how best we can bring them nearer to the normalcy. So I think in that way this is a very I think important endeavor, both by the researcher Wasim as well as his guide Gopee. And I do see that the outcome of this research will be a watershed for treatment of agrammatism. And the fact that their publication in Nature and Springer, one of the top peer-reviewed journals of Q1, is a testimony to the quality of the research. Okay, so in fact, I was just waiting and seeing whether this is say some kind of a rehearsal for his defense viva. Okay, but of course, he has to, of course, he has to finish his, I think there are lots of things to be done. I can see Dr. Gopee smiling. That means, there is a lot of things incomplete, but I'm sure that, inshallah, he will finish all that, and then, he will definitely be able to get a very productive, comprehensive assessment kit as well as the intervention kit. I personally, I enjoyed this presentation. Actually, I was a bit skeptical whether I would be able to understand, but I think he has really, made it very simple. And the number of questions which arose out of this session, wow! I must really congratulate Sonal, Chitnis, and the organizers of ISHA for so much of enthusiasm and so many questions. That means people really want to learn from these kind of webinars. So whether pandemic will stay or pandemic will disappear, but I think we will go on with such kinds of these academic discussions and then benefit from them. Okay, so hats off to once again to Wasim as well as to his great guide Dr. Gopee. Thank you for this opportunity.
Thank you so much,
Thank you
sir.
very much, sir.
Actually,
Yeah.
very well encapsulated the talk and the summary. You actually put forward very well how one has to actually work in Indian aphasiology in the context of how Wasim and Dr. Gopee has been working on the modern aphasiology aspects. And we got such enthusiastic responses from the participant that really shows that aphasiology interest, the clinical work has been actually expanding, and people are taking interest. They are wanting to learn scientific methods, approaches, techniques in evidence-based era. So it is really heartening, and I think that is a true full for the Aphasia Awareness Month, the beginning of what we have started the education series. So I hand over to the Joint Secretary ISHA to extend the vote of thanks. May I ask Sunil to unmute and give a vote of thanks, please?
Yeah. Good evening, everyone. I take this opportunity to thank Mr. Wasim, a close friend of ours, for accepting our invitation of SIG Clinical Aphasiology to share his knowledge about the verb network strengthening and the underlying basics of this particular therapy approaches and importance of that in the Indian context, and that is more specific and needs to be highlighted. Thank you, Wasim, for sharing your expertise on this. And I'm very sure that right now I'm seeing around 80 attendance, but otherwise, just before the question session, there are almost 127 participants, and which is quite a good number. And that too, especially only, I mean, the topic is only about the aphasia, and it's a really happy moment for all of us to see the youngsters joining us and trying to learn and trying to get more information about the field of aphasiology. Even though the topic is very, very narrow and very deep, people are still there. And thank you, Wasim, for making the talk so interesting for every one of us. And yeah, no words to say regarding Dr. Gopee Krishnan, sir. Thank you very much, sir, for accepting our invitation to be the moderator for this session, and that too for your own student. Thank you very much, sir. Thank you very much. And I also take this opportunity to thank the pioneers like Dr. Bello Rashekar, sir, Dr. Apurva Pauranik, ma'am, sir, Dr. Radhika Povia, ma'am, and many others who have joined on this particular lecture. And we from the SIG Clinical Aphasiology and also from Indian Speech Language and Hearing Association, we extend our sincere thanks to each one of you for being with us on this webinar. Thank you, one and all, and we hope to see you all in the future sessions, which is going to be which is scheduled on the 1st of July between 6 to 7 about the assessment of aphasia from a clinician's perspective. This is more like a cognitive perspective. It's not clinician, but it's a cognitive perspective. So that is again going to be a wonderful session. And we have Dr. Apurva Pauranik, sir, as the moderator, as the speaker for the session. And I request all of you to join for the same. Thank you, one and all. Have a good day. Stay safe.
Thank you. Thank you.
Thank you.
Thank you so much, sir. Bye, sir. Bye, Wasim.
Thank you. Bye. See you.
Thank you.